I think the faculty today needs no special introduction. She is Sister Sarita Singh. She will be continuing with the session, with the previous session. So she'll be doing part 2 of the gastrointestinal symptoms. So over to you, Sister Sarita.
Okay, thank you. Thank you. Good afternoon, everyone. The last week we have left the constipation portion. So today I will cover constipation first, then malignant obstruction second. So I'm going to share my screen. Is it visible?
Yes, ma'am. Please go ahead.
So constipation is one of the very important symptoms in the patients who are in palliative care or suffering cancer. So how you can say that patient is having constipation? There are some criteria which is known as the Roux criteria. According to this criteria, when you find two or more than two symptoms, then are present in the patients, then you can say that patient is having constipation. These are criteria. Number one, straining during bowel movement and lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal blockage or obstruction, sometimes manual evacuation, and less than 3 per week. If two or more than two criteria are present, but definitely two criteria are present in patients, then you can think that patient is having constipation. So prevalence, the global prevalence in the of the constipation is in the cancer. It is 23 to 65% patients are suffering the constipations who are suffering with cancer. In AIDS, 30 to 35%. Heart disease, approximately 40%. Chronic obstructive pulmonary disease, 44% of, and in the renal diseases, it is 70%. So more common the cancer and renal diseases, the patients are mostly having the complaint of the constipation. So constipation is of type functional or primary constipation or the secondary constipation. Secondary constipation is due to the origin is due to some previous disease. So the primary constipations are mostly the functionals. They are due to sometimes irritable bowel syndromes, functional constipation, functional diarrhea, functional abdominal bloating, unspecified functional bowel disorders, and opioid-induced constipations. These are the primary causes of the constipation. So secondary causes of uh, constipations are the diet and lifestyle. Structural causes like some cancer or colon cancer, or neurologic, there is some disease, neuropathy or autonomic neuropathy, diabetes mellitus, Hirschsprung diseases. Due to these causes, if the constipation develops, these are the secondary constipations. The endocrine causes, metabolic causes, there are various causes, various diseases which may lead into constipations. How you will assess the constipations? As I have told you, the Roux criteria. And apart from this, when the patients come to you as a nurse or as a sister, how try to assess the patient that patient is having constipation? First, ask the date of the last defecation and what is the frequency of bowel, what is the consistency of stool, recent changes in, is there any recent changes in the bowel pattern, or us to defecate, or there is not us to defecate. Sensation of evacuation is complete or not. Sometimes these the constipating patients are they very commonly say that there is not complete feeling of the complete evacuation is not there. So fecal incontinence is there or not. Evidence of blood or mucus on defecation is present or not. Current or previous laxative use, PI, and need for digital manipulation to assist or manage it. There is any thing like the patient has used manual. Sometimes So these are the questions by which you can assess that patient is having constipation if they are present. So these are the type of stool, the constipations which are sometimes you can explain to the patients when you are going to make the diagnosis of the constipation is the type 1 stool. Is the patient is very much constipated, then the picture of the type 1 is the this is the picture of the stool. And if the slightly constipation, then the type 2 is lumpy and sauces like picture of the stool. And if the normal, there is the type 3 sausage shaped cracks in the surface. This is the normal stool. And this is the type 4 is normal in fiber and uh, dormitory. So these are the picture of the stool by which you can take up some idea by asking the patients. So what investigation you will like to the rarely needed, that is abdominal X-ray and the serum calcium level, thyroid function test. But in palliative patients, we are not focusing very much on the investigation. We are going clinical history and the presentation of the patient for the constipation. Uh, this is the picture which is showing why morphine is responsible for constipation, because there are various receptors which are present in the GIT systems. They can cause the symptoms of the GIT morphine induced. Morphine induced, like if there is constipation, if there is constipation, then the morphine induced, because this causes the decreased gastric motility. Morphine is a drug which causes the decreased gastric motility and can cause the constipation. And in the there are other places where the symptoms come due to the morphine. So this picture is showing that my focus is on the constipation. So constipation for the morphine induced is why morphine is decreasing the gastric motility and leading to the constipation. De uh, Pathogenesis: decreased bowel tone and contractility, increased transit time, increased contraction of circular muscles, non-propulsive contraction, and fluid absorption. These are the pathogenesis reason behind this. Decreased contraction of the longitudinal muscles, which decreases propulsive movement, harder and drier stool. They form the harder and dry. So in short, I want to say that these are the activity which occurs in the intestinal tract and they produce these type of things. Inactivation of chloride channel and decreased chloride transport from the enterotile side, the gut lumen, which causes the less water flow due to the lower osmotic gradient, and which decreases the gut secretion and absorption of the water with less gastric and pancreatic secretions. So my purpose is to say that if the gastric motility is less, there is the staying time, the content is more in the lumen, which can cause multiple problems, which can cause the absorption of the more water from the stool towards the lumen and secretions of the this gastric contents, toxins. These can cause the problems in the constipating patients. So chronic constipation must include two or more than features: straining, lumpy or hard stool, sensation of the incomplete evacuation, sensation of anorectal obstruction, and blockage, maneuvers to facilitate defecations. These are the features which I have told earlier. And when these are present, you can say that patient is having constipation. What are the management? So there are various management, non-pharmacological as well as pharmacological. In the palliative patients, if the patient is, there are various causes of constipations in the palliative patients. So according to the first, treat the cause and identify the cause. If the patient is less mobile, less eating, not taking properly orally, then give him more fiber, more, whatever he can take, can provide the fiber foods, more liquid, more water, and these are the things. These are non-pharmacological maneuvers you can do in the patients of constipations. Make the patients mobile, allow him or her for some mild exercises, promote movements, encourage movements, and give proper time for the defecation. Don't make hurry to the patient, make the privacy to the patient so that he can defecate properly and complete evacuation may be happen. These are the maneuvers which we are doing in the palliative patients. So these are things which stress is also very the patients palliative as well non-palliative care as well non-palliative patients. Why how stress we can manage the patient. Palliative patients are always in stress. They are psychological problems also. So we can provide them by some counseling, yoga. You can provide them time management. You can provide music to stress so that if the constipations we can these are manual and this is very important also position the when the patient is good by difficult I explain the position also why position is in the sitting posture sometimes the rectalis muscles chokes the rectum to maintain continence but advise him or squatting position this will provide the easily and sensation of vibration. This is also an release the constipation. Oncological patient complaints of the constipations. First, the then assess the assess patient to constipation by the criteria. First, make the diagnosis that patient is having really patient is having constipation. Then exclude the intestinal obstruction possible or assessment of the causes. First, assess the patient, confirm the constipation, then assess the cause. What is the cause behind this? Whether it is in obstruction, it is medicine induced, or whether it is in disease induced, or it due to stress induced. Search the cause of the constipation and exclude intestinal obstruction. This is pharmacological management. So this is important in the palliative. You should always keep in mind. This is also important cause of the intestinal obstruction. Cause is correctable very first. Then the first line to constipation is the oral laxative. Combination of stool softener and a stimulant. This is the first line of the constipated patient. Patient is continuous if symptoms is not then
Ma'am, sorry to interrupt, ma'am. Your voice is breaking in between.
okay. Now it's okay.
Yeah, better, ma'am. Please go ahead.
So the first line treatment is the oral laxative, which may be the softener as combination of the softener and the stimulants. And the patient is relieved, then they continue the treatment. But if the patient is not relieved, then the second option is to consider use of the peripheral specific opioid antagonist. If the morphine induced is constipation, then you can go for the antagonist of the drug, or you can change the drug, or you can change the route of the drug to relieve the constipation. If the patient is relieved, then okay. If the patient is not, third line is the manual evacuation of the stool. Manual evacuation, the stool is not very common, but in palliative setup, we are facing with these symptoms. Sorry. Then next is the laxative. What laxative you can use? The most commonly we are using the bisacodyl and Sena or bisacodyl. That is bisacodyl tablet, two tablet SOS we are giving in the initial stages. Then very commonly we are using the syrup, cremafine, or paraffin oil. An osmotic laxative, sometimes when indicated in the morphine-induced constipation, don't try to use the osmotic laxative. Always give the stimulant. Because the reason behind this is the morphine causes the decreased gastric motility. So our purpose is to stimulate the gastric motility. So for this, we can use the bisacodyl or liquid paraffin. And other important thing in the palliative patients, if the patient is on morphine-induced constipation, then switch the morphine. The lesser constipating drugs like fentanyl is the drug of choice, but fentanyl in palliative care it becomes very costly. So we can use sometime buprenorphine patches. Sometime we are using methadone for the pain, which is less constipating. But in short, I would like to say if the constipation is drug induced or morphine induced, first use the stimulant stool softener. This is very effective and cheap and easily available. For this patient is relieved more or less. Otherwise, you can change your route of the drug. This is the picture of the constipation, X-ray abdomen. Which can cause the nausea, vomiting, diarrhea, delirium. These are the complications of the constipations: nausea, vomiting, diarrhea, delirium, urinary retention, terminal restlessness. So constipation is very important symptoms which should be treated in the palliative patients as early as possible. So my take-home message is constipation is a symptom, not a disease. Opioid-induced constipation is under-recognized, under-treated, and distressing. Prevention of the constipation through lifestyle changes is a very good idea, and you should try for the non-pharmacological measure first, then after that, pharmacological measure. Versus laxative with opioids. Thank you. The hand that write the opioids prescription should write the laxative prescription always. This was said by the damn sounds. In palliative patients, mostly the common causes of the constipations are immobility, lack of interest in the food. So encourage the patient to for the mobility take orally, they take more. And if the drug induced, so always try to give the laxative along with the prescription. Next one. Now I'm switching my next topic, malignant bowel obstruction. So my slides are visible.
Yes, it is, ma'am.
The next topic is the malignant bowel obstruction. What is malignant bowel obstruction? Malignant bowel obstruction is a frequent complication in a patients with advanced cancer diseases, especially malignancy of GIT and gynecological cancers. So the global prevalence is that malignant bowel obstruction is approximately 3 to 15%, and mostly they occur in the colon, ovary, stomach cancers. So disease associated, what is exactly malignant bowel obstruction? Malignant bowel obstructions means if there is any obstruction, this may be intraluminal or extraluminal, which obstructs the gut. This is the which obstruct the gut due to any disease or any tumor or due to paralysis. This can lead into the malignant bowel obstruction. The intraluminal tumors act as a point of the intussusception. Intraluminal tumors can impair the peristalsis of the gut, and the tumors which are expressing the gut lumen extraluminally towards from the outsider, they the omental mass, or they can lead into the they also obstruct the lumen. And the main story is that the malignant bowel obstruction is the obstruction of the GIT by any tumor, extra or lung. Sometimes surgery, due to the surgery, there are many adhesions, they also can malignant bowel obstruction. Sometimes stricture, there is formation of stricture in the area. They can also cause the malignant bowel obstruction. Intraperitoneal chemotherapy can also, these are the causes of the malignant obstruction. They can cause obstruction in the gut, human, and prevent their motility, and all the things that get stuck at one place, and they develop painful problems to palliative patients and the cancer patients. So they can, main sign and symptoms of malignant obstruction is the nausea. 100% patients, it is found in nausea and vomiting and colicky abdominal pain, abdominal distension, and absence of stool and the platters. So these are the sign of the intestinal obstructions. But here I want to say that there are two types of obstruction: the upper intestinal obstruction and the upper part of the GIT obstruction. GI obstruction. So in the upper part of GI obstruction, there is the huge amount of symptoms of the vomiting is more frequent, and the amount of the vomiters is large in the upper bowel obstruction. Why I am saying this, that can take just an idea that this is upper bowel obstruction or lower bowel obstruction. In the lower bowel obstruction, the frequency of the vomiting is less, but the vomiters come out with the fecal material or the fecal smells. Then you can diagnose that this is lower bowel obstruction. This is the pathogenesis. What happens in the malignant bowel obstruction? What is the story behind this? These are the symptoms, why these symptoms occurs in the malignant bowel obstructions. First, colicky pain. Why colicky pain occurs? Because there is obstruction in the lumen, and the GI tract tries to overcome this obstruction and cross this obstruction most forcefully. Forceful action. So this forceful action to overcome this obstruction causes the colicky pain. This is the story of the colicky pain. Why there is distension of the abdomen? Distension of the abdomen is this because the lumen content is stagnant and it is going collected. So amount and the area is become bigger. Lumen contents become more, and they get epithelial surface area is become more. So bowel secretions also increases bowel secretions, area is occupied by the content is more, because stagnant, there is no passing away, there is no way to pass this content. So there is collections of the material. This collection causes the distension of the bowel, and this causes the distension of the abdomen. This also leads nausea and vomiting, because there are many toxins, many hormones are also releasing, and they get stimulated the vomiting centers, and the patient is producing vomiting. Distension is also stretching, due to the stretching, patient present vomiting. So what happened there? The pain, there is a colicky pain, there is distension, there is vomiting. But there is another pain also, it's continuous abdominal, dull type continuous abdominal pain is also happening in the malignant bowel, in malignant obstruction. Why this happened? Because the damage of the intestinal epithelial is there, and the bowel inflammatory response with edema, because due to the stagnant, due to the stay of that area, is there is release of some prostaglandins, some increased circulation. This causes the hyperemia, inflammatory responses also occurs. So all these things combine together and cause the continuous pain and distension the abdomen. So these are the symptoms, that is colicky pain occurs in the malignant bowel syndrome, obstruction, distension of the abdomen, nausea, and pain, which is the continuous pain in the abdomen. This type of patients are having these symptoms with these background. So onset of obstruction is rarely an acute event. Partial obstruction may occur intermittently and resolve spontaneously. Vomiting with or without nausea may be happening in these patients. Nausea often relieved by the vomiting. In a small bowel obstruction, early vomiting, large in bowel and frequent. As I said, in the small bowel obstruction, can relieve the NG tube sometimes, but in the large bowel, there is no role of the NG tube. Large bowel emesis develops later on, and usually this matter come with the fecal smell. So what investigation you will do this type in palliative setup? I'm not in favor of high investigations, but up to some level, clinically we are diagnosing the patient and treating the patient in palliative setting. So first you have to explore at least hypercalcemia, because hypercalcemia needs treatment. So abdomen, X-ray abdomen, and X-ray abdomen, CT. The higher center CT is also, but our setup we are seeing the patient clinically and symptomatically. Sometimes the baseline of the blood investigations I know. This is the picture of the malignant bowel of abdomen. These are the dilated gas fluid filled small bowel. The important is this stress sign. See the stress sign. This is a small gut obstruction. And in the large gut obstruction, see this fluid levels and some string signs. These are string bit signs. So what is our goal of care? So now we are knowing that what is malignant obstruction, what are the symptoms, how the patient is presenting symptoms. Now, how can we help these patients? First, our goal should be adequate control of the pain and other physical symptoms. Maintaining optimal hydration and nutrition. Patient has NG tube, make sure tube is patent and output is recorded. Optimal management of electrolyte balance and sepsis. This is our goal of the management. So how you will manage? This is very challenging for the physician. We are facing a lot of problems with syndrome. The type of obstruction, the condition of the patient, and the predicted prognosis determine the treatment plan for the obstruction. Basically, these patients are very terminal stages. So psychological or and physical symptoms comes very frequently in front of us, and patients are naturally they are very terminal stage. So prediction and when how what you are going to do, that how much you will give benefit to the patient, this is very important. A meticulous assessment is necessary for the successful outcome. First of all, stop all laxative, especially the stimulant, and determine the need for the other medications. Encourage the mobility of the patient. Drug used for the symptoms management have to be delivered via a syringe driver. Oral route, you have to skip the oral route in the malignant obstruction and through the subcutaneous of the syringe driver that should use. Subcutaneous IV, sometimes IV fluid needed for the hydration, but mostly we are going through the subcutaneous fluid, subcutaneous infusion. For pain, you can use the opioids, is the drug of choice, but it is too costly for this patient. But if the patient is affordable, you can use the fentanyl by the calculation of the when you are going to switch the from morphine. First pain relief, then second is vomiting. For the vomiting, never use metoclopropamide when you are diagnosing as a patient is complete bowel obstruction, because it will increase the gastric motility. It is prokinetic drug, it increase the motility, gastric motility, and it perforation can occur very frequently. So if there is partial obstruction, you can use the metoclopramide, very norm. But if there is complete obstruction, never use metoclopramide. There are other drugs for the vomiting like cyclizine, haloperidol, 2.5 milligram, 10 milligram to 10 milligrams subcutaneous in 24 hours, levofloxacin, and other drugs you can use. The haloperidol is the drug of choice. We are using haloperidol, but the partial obstruction only use the metoclopramide. So antispasmodic and antisecretory drugs, what you will use? The hyoscine butylbromide, Buscopan, which decreases the gut kinetics, gut secretions, and relax the gut smooth muscles. This is very effective and useful drug in the. So you can start 20 milligrams subcutaneous stack and PRN 80 to 160 milligrams. Hyoscine butylbromide is also antiemetic. Glycopyrronium can use sedation, but it's IV, so subcutaneous you can use it subcutaneous. And other one important is the steroid. Steroid works very good as anti-inflammatory, as anti-edema, antiemetic for the nausea vomiting. So there is another drug, stomatostatin analog. This is octreotide. Previously, it was not available, but nowadays it is available in the market. But it is very costly. It is very helpful drug in the end. Decreases the luminal content, decreases the luminal motility, decreases the luminal congestion, and it decreases the ascites. In short, you can octreotide is a very helpful drug. You can use it. The anti-secretory effect throughout the GIT reduces the volume of secretion. If vomiting remains frequent, start octreotide. Change to the oral drug once the symptoms are decreases. Then you can come back on the oral drugs. Encourage the patient to have favorite beverages and food. Maintain oral hygiene and allow the patient sips of the food. Don't try to give more fluid IV or subcutaneous. These type of patients. So when interventional is these are the non-interventional procedures, methods which we are using in the palliative patients. But if when the story comes about the interventional indications, when you will for the intervention in these patients, when there is single disease or there is single obstruction or any adhesions, and patient is giving consent and all after all the uh, prediction about the outcome should discuss with the patient, their caregivers, then can for the interventional methods, but it should be beneficial, not the harm the patient. When you are going something, always think that how much it will give help or give benefit. If the patient's general condition is good, then no disseminated disease like any other or any neuropathy or any other major disease, independent and active patient is in good condition, then you think about the intervention. And when the intervention is the only choice, then you can go for the intervention. Otherwise, in the palliative patients, we are not thinking early stage for the interventions. So what are the contraindications when you will not decide for the that intervention is when presence of re-obstruction means patient is going many times for the obstruction, many times. Off and on is after 3 to 4 days there is partial or obstruction type of things. Then you will not take decision for the intervention. If there is diffuse intra-abdominal tumors, there is no marking of the tumor. Tumor is diffuse or it is spread all over the abdomen. Then you will not think about the intervention. Multiple palpable masses, if the metastasis is more, then you cannot think the interventions. Previous laparotomy hai, previous radiation therapy, in poor nutritional status, in poor general performance status, lung volume, large volume ascites, refusal to do surgery. These are the contraindications. They then have to take the decision for the intervention in these MBO patients. Must know when to operate, can provide relief of the symptoms for a significant period of time when performed in a carefully selected patient. So you should have to select the interventions or the procedures, whatever you are going in the patients. TPN is important in bowel obstruction, but in palliative, in terminal, we are not going for the TPN. We are not taking TPN, but the condition is good and patient is able to absorb that TPN solution and in good condition, then you can use the TPN. Psychological support, altered body image due to weight loss, cancer, cachexia, inability to eat or feed, side effects of ongoing treatment. These all are psychological support we have to give in any palliative patients in the form of physical, social, financial, spiritual aspect like that. These patients also can give the psychological support. In the conclusion, the goal of the treatment of are palliative rather than curative measures. So always think about the palliative methods of life, the limited life expectancy and the with limited resources. We have to improve the quality of life finally the patient. When such a decision is under consideration, chance of successful palliation, risk of repeat obstruction, quality of life of patient after surgery and after interventions, ability to administer further chemotherapy. When these are the conditions which are coming in front of us, then our aim should be the palliative rather than curative measure, and our purpose should be the improving the quality of life patient as well as their caregiver by decreasing their symptoms. So my key point is surgery, no. When all the things will fulfill, then you can go by the through surgery. Explain the patient properly what you are going to do and how much it will give benefit to the patient. Reduce vomiting, pain, and intestinal obstruction, intestinal content by the palliative measure, and use the accordingly drugs which is required to secretory antispasmodic means relieve the pain the patient and relieve the symptoms, improve the quality of life. Thank you. वापस कैसे आए?
Thank you, ma'am. Thank you so much for that wonderful session. Now it is open for discussions. Participants can put in their doubts. You can either unmute or talk, else you can put your questions in the chat box.
What is the question, ma'am?
Actually, there are no questions. I was asking them if they have any queries or doubts regarding this, they can ask.
Yeah, I do have one question. You mentioned a lot of subcutaneous drugs. So is subcutaneous used more frequently than IV drugs?
In a palliative setup, you are preferring subcutaneous rather than IV. Because
Okay.
in IV, we are giving in bolus and patient is so fragile, so that type of things he cannot absorb. Whatever you are giving to the patient should be able to accept that. This is the
Okay.
only purpose. Give this. In subcutaneous, you are giving slow drug, and in the IV, you are giving fast. So my patient is not so much prepared to receive the fast in the terminal stages, I mean to say.
Okay, thank you for clarifying.
Yes, thank you, ma'am, for that. And Sarah, I would also like to add, as ma'am has already mentioned, so we have patients mostly in their terminal stages, and mostly it could be mostly cancer patients. So in them, patent in IV lines are also difficult to procure, and it could be
Yes.
painful for them.
Yes.
So usually in our settings at Pallium also, we prefer the subcutaneous line more. Yeah, thank you.
That was I learned from you, ma'am. And by training time, you have taught me.
Ma'am, and also we have got a session separately on subcutaneous infusion that will be
Yes.
coming.
Yes.
Ma'am, we have got a question in our chat box. So the opioids ought to be always taken with laxatives, or we prescribe and instruct patients to take once they have reduced bowel movements. So that is from Michael David.
What is the question, ma'am? Patient is taking morphine.
Yeah, opioids ought to be always taken with laxative, or we prescribe and instruct patients to take once they have reduced bowel movements.
No, initially when we are prescribing opioids, the patient need laxative regularly, at least 1 week. We are prescribing at least 1 week initial stages. When the body become cope up with this system, then you can withdraw the opioid. But if the patient is having constipation, you have to come in contact regularly in the patient. If the patient is having constipation, you have to add constipation. But constipation is the symptom which is not accompanied with the body. When you are giving morphine, you have to give the laxative. But this is very rare. Some patients are not needed laxative. I have seen. But in teaching, I will always say that add laxative always when you are using the opioid, especially morphine.
Sarita ma'am, you are muted.
So question is, there is diarrhea. So if the patient is taking morphine and still is having diarrhea, then I think there is no use of constipating drug. What do you think, Dr.
The cause of diarrhea first. So, what is the cause of diarrhea? So here, every diarrhea, it doesn't mean that so I just want to put one more point. I don't know how many of you are familiar with the term overflow diarrhea or spurious diarrhea. It is a condition where, due to long-standing constipation or chronic constipation, the bowels gets obstructed and there will be a leakage of the feces from above the blockage. So this will appear as spurious diarrhea or watery diarrhea, and it is often mistaken as diarrhea. So there, the treatment would be, we'll have to, if it is a long-standing diarrhea, first we'll be doing the per-rectal examination. Then if it is need digital evacuation, then that has to be done. And enema or whatever, like if it is, mostly we give high-up enema for that. So unless you identify the cause of diarrhea, you cannot, so in stage 4 of AIDS, if it is diarrhea it could be due to a long-standing constipation, then the laxatives have a role. Otherwise, I don't think, I don't know. I would like to hear from other participants, what do they think about it? And ma'am, your comments also.
I'm agree with this. If there is spurious diarrhea, so this is the complication of constipation. This is not simple diarrhea, but first you have to go the cause of diarrhea. If there is a impaction of stool and proximal to this stool is unformed stool is coming out as a diarrhea, so you have to give the higher enema to relieve that impaction of the stool, and then this treatment, this is the only treatment for this. But first you have to diagnose the cause of diarrhea. What is the cause of diarrhea? There is infective, then you have to add some other drugs.
If anyone else have any queries, please unmute and talk, or you can put it in the chat.
If there are no more questions, I think we can move on to the case presentation. Today, Sister Pardon Sherpa will be presenting a case patient story for us. Sister? Over to you, sister.
Good evening, ma'am. Good evening, everyone. I, Pirin Ong Shirpa, from working as a staff nurse in Namchi District Hospital, would like to start my case presentation, and I'd like to start it with my patient details. My patient was 62 years, female, and she was diagnosed as ischemic colitis. And her presenting complaints were lower quadrant abdominal pain, bloody bowel movements, vomiting. She had fever, and she had urgency to pass stool with mixed with blood. And her history of illness where she had past history of deep vein thrombosis with atrial fibrillation and a long-standing constipation. On examination, she had quite distended abdomen with diffuse abdominal tenderness. And on investigation, her WBC and CRP count was abnormal, like increased. On CT scan revealed gaseous distension of larger bowel with no evidence of mass lesion. On laparotomy, larger bowel was quite distended. The macroscopic appearance of dusky large bowel mucosa taken together and history of atrial fibrillation led to diagnosis of her ischemic colitis. And on examination, she was conscious and she was oriented, and her temperature was 100 degree Fahrenheit. Her pulse rate was 140 beats per minute, and her respiration was 22 breaths per minute, and her BP was 90 by 60 mmHg. On treatment, on investigation, her WBC counts were 14,000 milligram, and our CRP was 40. And on the investigation done was CT scan and ultrasound. The medication she was given was antibiotics, that was Piptach and metronidazole, and the NSAIDs used to relieve her pain was diclofenac, injection diclofenac. Yes. Psychological aspects were she is 62 years old with her daughter who is married and stays in another city. Her daughter cannot continuously look or take care of her because she has to look after her child who is just 11 years old and is going to school. She also is facing financial problem due to her treatment, and her daughter and husband also doesn't earn enough to look after everyone and is running short of money because of the travel expenses. She is also left alone in the hospital because no one is there to look after her. The main concern is her pain and the financial issue. Summary, she is 62 years old female, diagnosed with ischemic colitis, and her family is also facing financial problem. She also has continuous pain. Discussion points are how can we help her in her psychosocial problems? Can we provide her palliative care at home? And the last one is how can we ease her sufferings? Thank you.
Thank you, sister, for that case presentation. If any participants is having any doubts regarding this patient story, you can ask her. Okay.
Can we take up the discussion points one by one? Sarita ma'am?
Yes. So first is how can we help her psychosocial problems?
I would like to hear from the participants. What do you all think about that? How can we help her in her psychosocial problems? Yeah, so Sushma has put in that we can provide psychological support. Can we go back to that slide?
Ma'am, if we can provide any caretaker from any voluntary care service means it's good, I'm thinking. Ma'am.
Yeah, so we have different opinions, getting some welfare or financial and NGO support. Then any neighbor or friend who can help locally to provide community palliative care center rather than hospital palliative care center. So many options have come in. Ma'am, would you like to talk on that?
Yeah, there are many.
Ma'am, you're muted, ma'am.
Yeah, there are many community health centers. They are provided some nurses or the manpower, that type of patients. I don't know, your places there is present or not, but our places there are community centers. They can provide the persons for seeing care after for this patient. We can give the address to this patient who has community center.
So to help her in her psychosocial problems, I think first and foremost, what we need is to address her concerns, talk to her in detail about what she wants to say, what are her real issues. So we need to explore from her what she wants to tell us. And once we explore the issues from her, I think we can also include her daughter. She might also have some concerns. So addressing the family concerns also would be another step. And of course, like what ma'am has said, and many of you have suggested, try involving the volunteers, volunteer support groups or community local groups who could provide a continuous support for them. And by going through the history, what we understand is that her daughter is also finding it difficult to take care of her due to her own personal reasons. So if there are some support groups whom we could identify who can spend time with her and share her, whom she could share her emotions with, I think that could be helpful for her.
Yes.
And I think there will be a detailed class of psychosocial concerns coming up for the group later. And also in Pallium, here we have volunteer groups and also local communities, local community leader volunteers whom we can connect them to. They are a very important group of people who can help us in such issues to support the patient and the family. I hope, I'm sorry, sir, is it Padam or how do we?
Ma'am, it's hidden.
Pidden. Okay.
Yes.
Okay. Yes, Pidden. Hope, are you clear? Or
Yes,
you have
ma'am.
some more queries on that?
No, ma'am. No, ma'am.
Shall we move on to the next discussion points? Can we provide her palliative care at home? Thoughts from the participants? Yeah, I think many of you have put in the chat box that can definitely be done.
Yes. We can provide her palliative care at home. It's more easy to cope up this patient because in hospital she is having no money and no any manpower type things. So at home she will be more comfortable.
Yes, so yeah, we can provide her palliative care at home. So once her acute symptoms are settled, and we can shift her to home and continue the management at home. So yes, that is definitely an option. So can what next discussion point? How can we ease her sufferings? I think we have almost covered, like, to address her sufferings means we have to address all the 4 aspects of care.
Yes.
So the physical, psychosocial, and spiritual aspects of care has to be addressed. So financial issue is also a problem. So there, in our settings, what we try to do is we try to publish stories in the social media. With their permission, we collect the stories and give it to the social media. And through that, we try to procure minor donors who could sponsor them with their or give financial support to them. These are one means that we do in our settings. I think many of you might have different ways. I don't know if anybody wants to share something that is happening in your setting. It would be nice for us also to know.
In my place, there are some persons who are willing to donate some money or some things. There are many people. So we mostly try to connect these person to that person. They are doing very well. Some societies are there. Some businessmen are also involved in this. They want to do some good work, paying society type things. So we keep their addresses, and when these patients come to our contact, we are connecting this patient towards there. So somehow we are getting that type of help.
Thank you, ma'am. Thank you for sharing that. Yes, yeah, I think approachable well-wishers and donors could be an option in such situations. Do anybody has any other suggestions or what you do in your settings? You might also have come across such situations where you know that the patient is suffering from financial issues
Yes.
and unable to take forward their treatment. Do you have any process or something that is being done in your settings? Sarita ma'am has shared hers. Could anyone else share their experiences in their settings? Or if you want, you can put it in the chat.
Ma'am, you are muted. Sarita ma'am, you are muted.
Yes, there are many financial programs from the government side are also running. So we can give their number to these patients. And in our government institute, there is all things are free by this cancer card patients are making. In government institute, mostly free. Treatment is free and all the things. But in private setup, it's quite difficult to manage the financial problems these patients until unless you will connect them some NGOs or
Yes, ma'am. Actually, we have a group of social officers who usually connects or facilitates them to the government schemes and policies that are available right now in our system. So they try to facilitate that. So that is, so in Malaysia, so we have a chat from Sansan. In Malaysia, we have social welfare and can claim our consumables from under Social Security Organization. Okay, okay. Oh, that is something new for us. So if we don't have any more questions or queries, Sarah, you wanted to say something?
Yes, I do have a question about the case study. And I don't know, maybe it could be a group effort to answer. I'm wondering what home management at home for this patient will look like. We talked about some of the psychological symptoms and different resources we could connect this patient with, but I'm just wondering what maybe treating some of the underlying causes might be. I'm guessing perhaps this patient is not a surgical candidate for the ischemic bowel syndrome, but would the AFib be treated so to try to prevent it from worsening? Because it seems like the ischemic bowel is secondary to atrial fibrillation. So I would just love a little more clarity on what is possible physically for this patient and what symptom management at home might look like.
I would request Paden to show some more light on that patient story. I think Sarah is asking more about the management part and how was it being done. So Paden has already mentioned that IV antibiotics were started, and also I think NSAIDs were given. So could you talk a bit more about that, Paden? How was the pain relief after that, or how was the patient?
I think Sarah point is very important because the patient is having cardiac issue also and ischemic bowel problem. So ischemic bowel problem, if you prolong it, it will increase. So it should be treated as early as possible because this is ischemic problem and cardiac problem also. So Sarah views how it can be managed at home, I think. Yeah. So it is important.
So it looks like she got antibiotics in the hospital and NSAIDs for pain relief. So those could be switched to oral and managed at home. And for atrial fibrillation, I don't know if they'd be on any rate management medications or anticoagulant like warfarin or something like that. I don't know what's available in the setting, but I was just curious.
I think we close to Sister Baden. She's having troubles with her network, I think.
I'm not sure what exactly happened in that patient case, but I think Sarah, once the acute scenario is being settled with and the infection is under control with the IV antibiotics, I think they can think about switching on to the oral medications and continue the care at home. I think that could be what she's planning to. I'm not sure. Ma'am, your thoughts?
Yes, I'm with you. If the acute problems are over, then patient can be kept on home, but there should be a frequent visit of the doctors because patient is having atrial fibrillation also. So there will be cardiac drugs timely given, and there will be a frequent visit of the cardiologist if possible. It's very good for the patient. But if the patient is in terminal stage and whatever anything cannot be done, then you can think for the palliative care at home. But if patient is treatable and it can be treated, so this is important that frequent doctor visits should be, because this patient is not malignant, and this. So these are the things.
So,
from my side.
yeah. So, Sarah, palliative care at home doesn't mean that she's not coming to hospital for
Yeah.
consultation at all, or a doctor is not visiting her. We have a lot of patients with cardiac issues in our home care, whom we regularly visit and who might be consulting their primary, like cardiologist, also on a regular basis.
Yeah.
But we do support them on our home visits also. I think this could be another alternative for her, where we can provide care for her at home with the psychosocial supports, covering all the aspects, not only the physical aspects, but all the aspects of care. And of course, she should be under evaluation and under monitoring on a regular basis.
Yeah.
Thank you. Thank you, Sarah, for raising that. Any other questions? Anybody wants to share something?
I think we can, if there are no more questions, we can wind up. Sister Pardon has lost network for her phone battery is down. That's why she got logged off. Sorry for that trouble caused. Thank you all for joining us today. We